Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. In today's episode, Dr. Alexandra Calmy from Switzerland and Dr. Jürgen Rockstroh from Germany provide European perspectives on some of the most important new antiretroviral therapy insights from HIV research over the past year. Specifically, our expert faculty discuss what has been learned from studies of two-drug regimens in real-world settings, their thoughts on rapid start and two-drug regimens, and other new and emerging drugs and innovations in HIV treatment. For more information about our guests and for additional online education on this topic, please visit the link in the show notes. So now, let's turn it over to Dr. Calmy and Dr. Rockstroh.
Hi, Dr. Rockstroh. It's a pleasure meeting you today. So we would like to talk about what is new now in antiretroviral treatment over the past year.
Well, that is really, if you think about it, quite a challenging question because of the wealth of data which was presented at various conferences last year. I think more formal drug development standpoint, we saw a lot of long-term follow-up, whether it's the 5-year bictegravir TAF-FTC data or long-term data from the 2DR 3TC dolutegravir development program, really confirming that after extended follow-up years of 4 or 5 years, we still see no resistance, low discontinuation rates. I think that tells us that antiviral therapy has really developed quite substantially. And the question a lot of clinicians always have is, how does that translate into real life? I mean, if we go into more challenging patients who wouldn't be included in clinical trials, do we really have the same findings? And I think that was another really quite a conference-filling spot this last year, where we saw numerous efforts. I'm particularly familiar with the ones from Germany. Obviously, we had different German cohorts analyzing the use of TDR therapy. And I think what was amazing for me is that, again, there was really no resistance development. It also told us, though, that people were more likely to use 3TC dolutegravir in the context of switch strategies rather than in naive. And I think that relates to some of the issues that people still feel that there's some caveats, also the guidelines around higher viral loads. Would you see that differently? I mean, is 3TC dolutegravir having the same place as a 3-drug bictegravir TAF-FTC regimen? Or would you say, looking at guidelines and the high viral load criteria and things like that, does that have an impact on you?
Yeah, of course. I think the question of starting a treatment with a 2DR, 2-drug regimen, if you do not have data or the results of your biological test regarding HBV, for example, so that may make some people be reluctant to really start directly with a 2-drug regimens. But maybe I just would like to complement what you just said on the real world data. What also was quite impressive in 2022 is that we now have very long-term data also for randomized clinical trials. And I think it has to be mentioned that randomized clinical trials are now encouraged to extend the follow-up up to 4 or 5 years. And we have seen the results of the Tango. We have seen results of the 3 years of the simple HIV trial. So we also have long-term data, not only from cohorts, which was generally the case for the randomized clinical trial that generally stop at week 48, but also from randomized clinical trials. So we do have really robust data that show that we can use 2-drug regimens, at least in maintenance, and certainly also to start treatment. But I think one of the issues to answer your question is that most people would want to have the results of the biological test more rapidly before they can decide for a 2-drug regimens. But that, I think, may be a detail, but what we have seen in 2022, that whether for naive patients or for patients already with a virologically suppressed viral load, we can start without any safety issue or efficacy issue 2-drug regimens. So this is very reassuring. And I think this is also one of the 2022 highlights.
Yeah, I mean, I was kind of surprised that we saw a lot of data from North America looking at studies looking at rapid start. So basically, you have your positive HIV test, and then you start your treatment without waiting for baseline viral load or a resistance test to come back. And I think that's quite interesting. There is a strong push from North America that this is the best approach ever. I think in Europe, my feeling always is that we are maybe a little different, basically because our linkage to care is so much better. I completely understand that in certain areas of North America, there are real issues of linkage to care. And if you look at the 95, 95, 95 figures, the famous one, you can see there's really a drop at the second 90 or 95. Whereas in cities like London, you have 95% linked to care. So that's not the issue necessarily in a European setting. And I was struck that the BIVA guidelines, which really specifically said, made a statement around rapid start, said you sort of have to discuss the pros and cons of rapid start. And unless someone is in seroconversion or really wants to be treated, and we all appreciate and acknowledge that there are individuals who have been newly diagnosed with HIV who want to be treated because they want to be undetectable and not transmit the virus, that it may also, be okay to wait 1 or 2 weeks to have all the results back and then maybe start at a safer ground when you know the hepatitis B status and maybe have a resistance test back, which may guide you in your decision-making process. But I see there's kind of a little bit of a difference in how North Americans and how Europeans deal with this rapid start issue. But in the end of the day, it's not too much difference. I mean, everyone's going to start eventually, whether it's 2 or 3 weeks into the overall treatment process. I think probably doesn't matter that much, at least in our current setting.
Yeah, maybe. I think there are at least 3 situations in which I really believe we should rapidly start. As the primary HIV infection, of course. Yeah. Then I think in a setting of the primary HIV infection, we wouldn't want to start with a 2DR regimen. I don't think it is recommended anyway. Another situation, maybe we should start rapidly with a triple drug regimen is in the setting of a PrEP failure. In that situation as well, maybe it's good to start rapidly with a triple drug regimen. And also the third reason is the patient wish. I mean, we do still have patients who really want to start very quickly. And for those patients, we have to be able to start quickly. But I tend to agree with you. I mean, what means rapid, probably 7 days, is also very rapid. If we have a good contact with the patient and we're sure that we won't lose the follow-up or lose the option of linkage to care, I think this is perfectly reasonable as well. So,
yeah. No, that was a great demonstration of cases where you want to start immediately. The only other situation I can think of is people who present with symptomatic HIV infection, where you obviously don't want to wait very long, or some people who are diagnosed with an AIDS-defining event that comes along with HIV tests. And there we know that very rapid initiation of ART is associated with a survival benefit. Now, obviously, we did not only have 2DR in oral formulations, but we now have new modes of administration. We can administer at least cabotegravir pivirine intramuscular, and that obviously also led to a whole plethora of implementation studies. And maybe I can start by giving my personal experience from the German kind of implementation studies, because we participated in them, and they were really twofold. The one was looking more at reasons why patients living with HIV would want to switch to a long-acting regimen. And I think that was kind of interesting, because it is surprising to see how high the number of people are who feel that they are daily reminded of HIV, or they are afraid that they are disclosing their HIV status by taking tablets in front of someone. So they're not necessarily known positive in the living environment they are. And I think that's something we shouldn't forget as physicians, that there are a lot of people who are still dealing with HIV-associated stigma, and a daily reminder in form of a pill can also be a disclosure to others, is really a sensitive issue. So I think that was kind of interesting. And then the other one was really to see in people who did not participate in the clinical development program, how efficacious and safe was this regimen in the hands of people who are not used to giving intramuscular therapies. And I thought that was amazing, because the selection of patients was very, very good. And the rate of virological failures was almost lower than in the randomized clinical trials. I think people learned from the results, but still there is that one individual or two individuals who develop virological failure and then eventually come down with resistance, which is a little bit different than the before mentioned high genetic barrier we have with our classic second generation integrase inhibitor, be it in a 3-drug or 2-drug regimen, where basically we see no resistance at all. So I think that's still something to discuss. But these issues around stigma and disclosure, I think, are maybe more important than we initially perceived. I don't know, how's your experience with long-acting?
One specific issue for aging patients who have many comorbidities and for whom the long-acting may be less attractive because they do have a lot of pills to take every day, etc. So in my experience, not everyone wants it. especially people who have comorbidities, they are used to take pills and they don't really mind about whether this is an HIV pill or a hypertensive pill. But other than that, I concur with what you say. We have seen a lot of patients who were relieved not to have to think about HIV every day. And this is very clear. But maybe with this very high rate of virological suppression on long-acting in the prospective cohort, especially the one in Germany, Dr. Rockstroh, it was for me quite, even though I'm coming from Switzerland, I've seen that more than 97% of the patients in the Carlos prospective cohort have had this injections visit occurring within 7 days of the dosing windows. This is quite amazing. If you also think this was done during the COVID period, I guess it was during the COVID time, this shows that people do not miss their injection time. And this is a very good point, probably also because some of those patients were selected because they wanted to have this long acting. I don't know what you mean, what you think, Dr. Rockstroh, but for me, it was like 97% coming on time to get their injection in clinics. Wow, that's much better than the missed appointment that we have here in Geneva, for example. So I don't know how you did.
Well, Germans are becoming very Swiss. I think that's part of the story. But I think what that tells me is that people have been very careful in the patients they select. And I think the question is, though, is that going to remain that way? And I can give you an example that in our clinic, we have been discussing the use of cabotegravir in some individuals where it is really off-label. So we're taking patients who are replicating but cannot adhere to a daily therapy. So they're willing to show up. They love their physician. They show up for the checkups and everything, but they cannot take tablets on a daily basis. And we have this one guy from Brazil, and he was just not controllable, with regardless which regimen, what genetic barrier, whatever. Because of the high genetic barrier, he never really developed resistance, but he was not suppressed for longer periods of time. And so we said, well, you come regularly, so we're going to try that with the injections, even if it's off-label. We'll explain it to him. And he's willing to do that, and he's been suppressed since. So I think, so for some selected cases, I wonder whether these long-acting could also be used for people who just can't adhere to a daily oral therapy, and then play out the advantage of, just having to have that in a certain time window. But I would agree that what you're worried about is what if you have very adherence challenged people also with regard to follow-up dates, and then they don't show up in the window, and what are you going to do then? So I think there are obviously a lot of remaining challenges and questions here, but I think it is still of importance. I think the thing which makes us worried, though, is obviously that there is the risk of resistance development in the setting of virological failure. And I thought some of the more important analysis around the long-acting therapies last year were nicely put forward by Chloe Orkin at the Glasgow conference, where she sort of tried to analyze risk factors for virological failure. And it really looks as if rilpivirine-associated mutations prior to switching to the long-acting therapy is associated with the highest risk of virological failure, which really means that if people ever failed before, or even with transmitted resistance, it's important to still do genotype resistance testing to get that information. But there's also other factors which have been identified, including the A1A6 subtype. And I think that's at least of concern, as I'm sure you're seeing Ukrainian refugees as well. And that seems to be the predominant genotype they have. So I think we're going to see increasingly patients from Eastern Europe with that subtype, where you wonder whether then that's the right choice.
Yeah, I think we have learned quite a lot now after all these randomized clinical trials. And we know a little bit more about these multivariate models for factor associated with virological failure. And with these three factors, the rilpivirine-associated mutations, the A6 subtypes, as well as the BMI, we now have really easy factors that makes us think that maybe this patient is a little bit more at risk for failure. Overall, the failure rate is really low. I do agree. I think it's interesting that we know who will be more at risk, maybe to enhance the virological monitoring of those patients, or to discuss other options if we can. But I think we have now really learned about how to use, how to care about those patients. Maybe we learn also to know a little bit more how to use off-label long-acting drugs for those, as you mentioned, who are not fully suppressed. And this is, I think, extremely important, especially for the adolescent population, for example.
Yeah, completely agree. always a little afraid when people say BMI plays a role. I always hope BMI plays no role. But I remember that Chloe said in her talk that BMI probably plays the least role of all. And we should remember that in the randomized clinical trials, that initially some centers did not use the right needle length. So I think with regard to BMI, probably the most important thing is that there's a proper injection, which can be challenging if someone, has lipodystrophy, for example, or has, a very high BMI, then it may be difficult to have the right needle. Now, obviously, other long-acting agents have also made it in 2022, at least to be registered and approved. And that's clearly lenacapavir, which has been studied in different patient populations, but among all is now licensed for the treatment in people with multiple drug resistance and drug failure to multiple drug classes where it's not otherwise possible to construct a new regimen. So my question to you would be, how did you perceive the lenacapavir data from the Capella trial and your overall impression of that drug?
Well, I think we have here a new drug with a new mechanism of actions, and we are very, very happy to see a really long-acting 6-monthly subcutaneous drug, because it opens also door for self-injections. It has not only been studied for highly treatment experienced patients, but also in naive populations, although we don't have the final results of the study for the naive patients. But I can see the interest of having a very long-acting drug to be maybe self-administered. So yeah, lenacapavir is interesting. Also, we have been, I don't know what you think about the resistance data for lenacapavir. It may not be the high genetic barrier for resistance as we would have hoped. It is still interesting, of course, still very important to have that drug. But one issue is that we don't have the right partner for the 6-monthly administration of subcutaneous lenacapavir. What do you think, Jürgen, with that?
Yeah, no, I absolutely agree. I think the occurrence of resistance in treatment naive as well as in treatment experienced patients tells us that the genetic barrier is not that of a boosted PI. I think the occurrence of resistance in the Capella trial was related to individuals who either had no other active agent or who were not adherent to the rest of the medication. But that tells us that there is a value of having another active drug in the trial. I mean, if you look at the results they presented at ID Week, there was not too much difference whether you had one or two other active drugs on board. I think the problem, though, is that we sometimes don't really know what is active. I mean, if you have a drug like 3TC and you give that on top of a 184V mutation, you would say from a genotypic resistance test, it's not active. But we all know that keeping the 184V has an impact on viral fitness. And we know from PI studies that if you have an M184V and you get a boosted PI plus 3TC, you're going to do still much better than if you don't get the 3TC, even though all of them had the mutation. So I think it's a little difficult how we judge what's active or not, because sometimes preservation of certain mutations may also be very beneficial. I would agree that there is room for exploring lenacapavir probably also in the PrEP scenario, and I'm sure we're going to see more data for this very interesting compound. Now, there's obviously also other drugs in development, and one drug which unfortunately had a stop of the trial program was islatravir, which is also a new mode of action, translocation reverse transcriptase inhibitor, which unfortunately dose-dependent led to lymphocytopenia. And that's why the trial program was stopped to find out what are the reasons, what would be a safe dose. Now they came back and said there's a safe dose of 0.25 milligram, which can be explored further. But there are some limitations. It's going to be studied in the low dose, which means it's going to be studied in a once daily formulation as a 2-drug regimen, for example, with doravirine, but it will not necessarily move forward in the 4-weekly as it was being studied in PrEP, for example. So how would you judge that? Are you happy that the trials resume, at least for treatment, or what challenges do you see along the way?
Yeah, this was a huge disappointment, I think, not only for the manufacturer, but for us all, because islatravir was dosed with so limited doses that even the highest dose was 2.25 milligrams. So, I mean, it's really small dose that you could have think about an implant. So other ways or other modes of administration that were really appealing. But I still think it's good that islatravir is gone back into trials. It was a dose-dependent effect on lymphocytes that was demonstrated with the improvement with dose reduction in trials from 2.25 down to 0.75 dose. And now they resumed the trial with a 0.25 dose. So I think it's always good to have drugs, a new drug. We will learn. What we have also learned is that it's not a mitochondrial effect as we had with D40 at a time where also we reduced the dose of the D40 from 40 milligrams down to 30 milligrams. But it seems now that we're talking about 40 milligrams and 30 milligrams, that it's huge doses. With islatravir, we are talking about, very, very limited amount of API, of the active ingredients. So I think it is important for treatment. Some hope that it may still build another brick in the wall in the treatment options.
Yeah, so I think in summary, I think what we can say 2022 was a year full of new data around antiviral therapy, and who thinks that HIV medicine has become boring clearly was disappointed, because there's a lot of new data emerging, and it tells us that, yes, second generation integrase inhibitors have a high genetic barrier and are great therapies, but there's still room for other improvements and angles that we can turn, and probably mostly around new modes of delivery, which allow sort of flexibility for individuals living with HIV to live a life with less HIV stigma.
Sure. Also, new drug, we need that the pipeline is keeping on. We need a rich pipeline. There will be new drugs, but also new biologicals for HIV. So indeed, I do fully agree. I mean, it's not at all boring. We need to look what will happen in 2023. We're very happy to look forward.
Thank you, Dr. Calmy and Dr. Rockstroh, for sharing your insights with us. And thank you for listening. Look out for more episodes in this series at clinicaloptions.com/HIV.